Hello, welcome to the ASGE Video Tip of the Week. I'm Dr. Chris Thompson from Brigham and Women's Hospital, and I'm here with Dr. Austin Chiang, one of our bariatric endoscopy fellows. He's going to tell us about a case that we did earlier today.
This is a 35-year-old morbidly obese female patient who was hoping to undergo weight loss surgery, but was experiencing intermittent burning epigastric pain, and therefore was referred directly for an upper endoscopy with us prior to her surgery to evaluate her symptoms.
Here you see the upper endoscope advance through a normal appearing esophagus. Upon traversing the gastroesophageal junction, however, a medium-sized hiatus hernia was encountered. Identification of hiatal hernias is important as this could alter the surgical approach for this patient. Careful assessment for any gastric lesions, such as ulcers or polyps, was performed throughout the endoscopic evaluation, including retroflexion in the stomach. The pylorus was then traversed, and the entire examined duodenum appeared normal. Here, duodenal biopsies may be warranted to rule out celiac disease if the patient is iron deficient, for instance. Upon returning to the stomach, biopsies for H. pylori are recommended in the antrum, as pictured here, as well as in the gastric body. The endoscope was then withdrawn, but upon closer inspection of the gastroesophageal junction, an area of grade A esophagitis was identified. This was biopsied. The remainder of the esophagus appeared normal as the scope was withdrawn. The patient was prescribed a proton pump inhibitor given findings of esophagitis. Gastric biopsies for H. pylori and biopsies of the gastroesophageal junction are currently pending. Repeat upper endoscopy is planned to assess healing of the esophagitis and to confirm H. pylori eradication. Roux-en-Y gastric bypass would likely be preferred over sleeve gastrectomy given the magnitude of the hiatus hernia and evidence of reflux esophagitis. The hiatus hernia should be repaired during surgery.
Endoscopic evaluation is just one component of a multidisciplinary preoperative evaluation. Many U.S. centers of excellence perform upper endoscopy prior to surgery, even in asymptomatic patients. However, there's no clear consensus on this. Findings certainly may impact medical and surgical management, and evaluation may minimize adverse events. It is clear that any clinically significant GI symptoms should mandate endoscopic evaluation. Additionally, more than half of asymptomatic patients have microscopic pathology, such as esophagitis or H. pylori infection. Examples of abnormal findings that could impact surgical plan of care include hiatal hernia, peptic ulcer disease, or gastritis. Other incidental lesions also include gastric or esophageal varices, polyps, malignancy, or evidence of gastroparesis such as Bezoar's. Abnormal findings on endoscopy may delay the surgical procedure or impact medical management. One study showed 7.8% of endoscopies altered surgical management. This may include a hiatal hernia repair being performed prior to or during the bariatric surgery, or altering the actual surgical procedure, potentially from a sleeve gastrectomy to a gastric bypass if there is the presence of reflux esophagitis or a large hiatal hernia, or perhaps altering from a planned gastric bypass to a sleeve gastrectomy if there is an unusual lesion in the stomach, especially if there is a family history of gastric cancer. Additionally, the finding of H. pylori, gastritis, or ulcers could also delay the timing of the procedure. Furthermore, 27.5% of endoscopies in that study led to altered medical management. This can include medical therapy for reflux, gastritis, or H. pylori eradication, or perhaps biopsying of the stricture, or need for further imaging prior to the surgical procedure. It's also important to assess any potential causes of iron deficient anemia preoperatively. This is for several reasons. There are high rates of iron deficient anemia post-surgically, especially in gastric bypass patients, where up to 61% of patients develop iron deficient anemia. This could also impair weight loss due to a variety of factors, including fatigue. Additionally, patients with a degree of iron deficient anemia going into surgery could have worsening iron deficient anemia following the bypass of the proximal small bowel. And certainly it's easier to evaluate this prior to gastric bypass because biopsying the duodenum to rule out celiac disease, for instance, can be rather complicated following gastric bypass surgery. H. pylori assessment is very important in these patients, even if the stomach appears totally normal. And we always do antral and gastric body biopsies to exclude the presence of H. pylori. If it is found, it's always eradicated, and that eradication is confirmed prior to going on to surgery. In this series of 64 patients with gastritis on preoperative endoscopic evaluation, 9 were H. pylori positive. There's a lower incidence of post-procedural marginal ulceration if H. pylori is eradicated prior to the surgical procedure.
So after the endoscopy and the note that is sent back to the bariatric surgeon, how specific are you in your recommendations based upon your endoscopic findings?
Well, we want to convey anything that might affect their decisions moving forward with what procedure they're planning and maybe even timing of their surgical procedure. So we start just with our history. If we discover something during our discussion with the patient, such as a family history of gastric cancer or something concerning like that, we'll certainly put that in our note back to the bariatric surgeon, because if there is a family history of gastric cancer, or potentially they come from a location with a very high prevalence of gastric cancer like Korea or Japan, the surgeon may not want to proceed with a gastric bypass where you have a large remnant stomach that can't be easily evaluated. So we'll mention that, of course. And then as far as specific endoscopic findings, if we see bad erosive esophagitis, maybe gastric polyps, any other findings that are concerning, we'll certainly mention that to the surgeon as well on that note. And for instance, if there's bad esophagitis, or in this case a hiatal hernia, those patients might not do well with a laparoscopic sleeve gastrectomy. It tends to be a reflux-inducing procedure anyway, so they may want to think twice about that. If they're going to proceed with it, they certainly need to repair that hernia first. So we certainly will highlight that in the note back to the referring surgeon.
Thank you, Dr. Thompson.
Thank you.